Does any of you have experience of volunteer? On COVID in geriatric patients, because I think it's really actual, so we can share this. I think it could be useful. Would you agree? Perfect. Okay. So I will wait the last 4 minutes until it's 2 because maybe other people would like to join us, and then I will share the presentation with you. We can start with the pharmacotherapy in geriatric patients so that I can help you to prepare for your state exam. And when we have this done, then we can continue with the news concerning COVID in geriatric patients. Yeah, now we are 12 of us. That's very good. Any questions now? Everything works technically for you with the Adobe Connect webinar? Everyone can see and hear? Mm-hmm. I'm sorry, I had to turn off 2 mics. Probably they were causing this noise. Um, I will change again. I will start your mics, but please turn them off at your side so that you can change when you want to speak, okay? Yeah, it's yeah, there are new people joining the group, that's fine. So I'm accepting the quiz section of this webinar. So I will try to send it. Yeah. Um, Now you should see the first questions. The first question, do you remember what does stop criteria mean? And please, could you choose one of these? Thank you very much. I am just trying if it works because it could be fun with these quizzes. Perfect. Yes, thank you for participating in the quiz. And still people are joining. This is fine. We are 17 now and even more people still coming. If you are new to the group, you can vote in the first quiz we have here. I see someone has changed his mind. List of no-go places is not so popular. Okay. So thank you for your vote. Everyone can see the quiz, the possibility. You can mark your choice now, and then I will finish this quiz. I think I will offer 1 more minute to those who would like to join us, and then we will start. So if you still want to vote, you can vote in the quiz. Everyone can hear me? Does it technically work for you? Also for those who came just recently in the group? Yeah, perfect. Okay. So welcome. Okay. So I stopped the quiz, and I can see that 78% of you thinks that stop criteria has other meaning. So could any of you please write me what are stop criteria good for? They are not for false. They are for something else. It's expert consensus. Medications to be stopped. Yeah, it is connected with polypharmacy. To prevent inappropriate prescription. Yes, thank you. This is exact. Thank you very much. That's great. I see you know a lot about this. You remember something from your fourth year. I'm very happy about that. So now we will just quickly go to make the summary of pharmacotherapy in geriatric patients. And I see I can be quite quick because you really remember something, or maybe you saw the presentation which was connected with these your lectures. And when we finish with pharmacotherapy, with the most important topic for your state exam, then we can go for the topic of COVID, of coronavirus, and discuss actual situation. So now I will start to share the presentation with you. I hope it will work with you. Okay, so and now you should see the presentation. Does it work for you? Great, thank you. Perfect. Okay, so welcome everyone. I'm Hanna Vankova. I'm geriatrician from the third faculty of medicine, and Before your state exam in internal medicine, we will summarize what you know about pharmacotherapy in older age. There are many changes in pharmacokinetics and pharmacodynamics which play essential role on the effect of pharmacotherapy on these patients. We have also counted polymorbidity and polypharmacy. And we never can forget compliance, cooperation of the patient with the regime of medication. So we start with changes of pharmacokinetics in old age. One of the most important is the change of total body water. It is much lower, and so the volume of distribution is lower, and this leads to the situation that hydrosoluble drugs are much more available. They have higher biological availability, and the examples are digoxin, lithium, or methotrexate, dangerous drugs which have a very narrow therapeutic window. This means that the dose which is important for treatment is very close to the dose which could be harmful. Other change is that the total body fat is higher, and this means that the risk of toxic accumulation of lipid-soluble substances is higher, especially in diazepam and other benzodiazepines. This accumulation may be really high and very risky. Other important point is hypoalbuminemia, which leads to a higher free fraction of drugs which are bound to albumin, and you see the examples warfarin, theophylline, or digoxin. Now I could ask you, would you know how many percent of warfarin are the free fraction? Because warfarin is bound to albumin, and the free fraction is only some proportion, and this free fraction is responsible for the whole effect of warfarin. So would you have any idea how many percent of warfarin are the free fraction? Could you maybe write it? I see 3%, 1%, 95. I see others are still writing, so I will wait for your suggestions. It is low. Yeah, it is. Okay, thank you for a suggestion. So it's 1%. Yeah, so it's just 1% of warfarin, which is free fraction, responsible for the effect. And imagine if the albumin, which is unstable, it changes really quickly from day to day. So if the level of albumin changes in blood of your patient, then also the effect of warfarin changes. The patient eats the same pill, but the effect may be very different. Other changes in pharmacokinetics concern changes in liver biotransformation, which are really important and not so known to physicians, especially drug classes which normally have very high first pass effect in liver. In geriatric patients, this first pass effect is much lower, and this leads to higher biological availability. The examples of these drug classes are again benzodiazepines, beta blockers, calcium channel blockers, morphine, PPIs, or statins. So these really important, very much used drug classes normally have high first pass effect, but not in geriatric patients. This means that their biological availability is much higher in geriatric patients. I welcome the new participant. Welcome, Liban. We decided to go quickly through all the specifics of pharmacotherapy in older age, and when we finish this, we can continue with actual situation on COVID epidemic. So now we continue with with the examples. And there you can see the example of quetiapine. This is modern atypical antipsychotics, and it's one of the safest. Could be used in Parkinson's disease. If you really have to use one antipsychotic, then you choose quetiapine. The usual dose for an adult would be 100 milligrams or even more hundreds. But for frail geriatric patients, we start just with 25 milligrams or even half of it. So you see how small dose we can use in geriatric patients. I should show you once again this blue instruction which summarizes clinical attitude to changes in pharmacokinetics. The most of changes in pharmacokinetics leads to higher biological availability. So what we do as clinicians is that we start low and go slow, and my European colleagues add, but go. So what does it mean? For example, with the quetiapine, we start, I'm sure you remember that polypharmacy is usually called the situation when there are 5 or more drugs, but also some other cutoffs may be used. For example, clinical pharmacists say that even using 3 or 4 drugs is already clinical experiment, because in usual RCTs, usual randomized controlled studies of pharmacotherapy, usually just one drug is examined, rarely 2 of them, and very rarely 3. So when you as a clinician use 4 drugs in one individual patient, then it's clinical experiment, and you should be aware that this is really unique experiment in a unique person. It's important to remember that polypharmacy itself means higher risk for the patient. There is another number, the number 9, you can see in the presentation, and this is the number when you should expect unpredictable problems. This means that even very sophisticated software which could predict interactions is flooded when it's 9 or more medications, and starting with this number you should expect not only predictable but also unpredictable problems and interactions. Another topic is compliance, and I'm sure you remember this from our previous seminars and lectures. At least half of all the adults make mistakes in medication. This is what literature says, but I would expect that even much more, because it's really difficult to follow the medication regimes. Maybe now in your 6th year you have much more experience, and you could tell me how difficult it is for patients to follow the medication regime. We had one international seminar with the European geriatricians, and it was for a week, and the Monday seminar was focused on polypharmacy. And what we received M&Ms, yes, the sweets of different colors, and a difficult list of instructions. And this list said, okay, so green M&M you take only on Monday, Wednesday and Friday, and the other days you take only half of it. The blue M&M is this and that, one you could take only on certain days. The other one you take only if you have certain symptoms. The other one you take always just once a week, but you have to stay in sitting position or walking position after swallowing it. And these instructions were so difficult, we had to follow them for the rest of the week. The bravest ones were able to follow the regime until Wednesday, but some of us made first mistakes already on Monday. So it's really a challenge to follow difficult regimes in polypharmacy. And the other aspect is that some patients simply do not want to take their medication. They are afraid, they had some side effects, and they do not want to eat it, and they are afraid to tell the physician. So always remember this, that when your perfect treatment, which you had so much work to invent to apply the best treatment for your patient, and when this doesn't work, always remember there is a possibility that the patient just doesn't eat his pills. And the best thing is just to ask, do you eat this medication? And when you ask, the patient will tell you. But if you do not ask, probably the patient will not bother you, will not dare to tell you themselves. But if you ask, they usually tell you, and you can cope with it. The most frequent side effects caused by medication are named here, like indigestion, dizziness and falls, fatigue, or acute confusion. So remember that these side effects very frequently support non-compliance of patients when they do not like their medications. If you have suspicion that certain symptom is caused by certain drug, if possible, you will try therapeutical test of withdrawal of suspected drug. Here you have the overview of drugs which are most frequently connected with falls. I think you remember this table from previous seminars. And we can move to stop criteria. So stop criteria, as we had in the quiz, they are about medication, they are about potentially inappropriate prescriptions for older people. So you can say it's a blacklist of medication where the risks are so high that they are bigger than potential benefit of them. Examples: TCAs, neuroleptics, antipsychotics, especially as long-term treatment and especially in indication of hypnotics. The other example are benzodiazepines. We can talk about them later when we discuss the panic connected and the stress connected with COVID pandemic. Then we can discuss how to relieve our patients who are very stressed, and we can discuss also the issue of anxiety syndromes and panic, if you want. So I will then change this mode to discussion again, and we will discuss it. Another example of stop criteria, loop diuretics when used as first-line monotherapy for hypertension, because there are much safer alternatives. And also any duplicated drug class prescription. This means 2 NSAIDs, 2 SSRIs, 2 ACE inhibitors, and so on. They are always inappropriate. So I will change again to the mode of discussion. And do you have any question about stop criteria? You can ask me now, I will hear you if you open the mic on your side. And I check if everyone who wanted to join the group has joined. Yes, okay. So any questions from you? There is a question, what about renal clearance? It is very well known that the renal clearance is lower in geriatric patients, so it's another factor contributing to higher biological availability of drugs. And especially renal clearance is usually well addressed when you read the official information about medication, but the other changes, like change biotransformation in liver, they are usually not addressed. So it's very good to remember them. And because each drug in combination with individual comorbidities and individual polypharmacy, it's so difficult to predict how the biological availability will be. So the easiest way to manage this as clinician really is that that instruction start low, go slow, and you will see and you will assess the effect. Any other questions? Okay, so if there are no questions, we can move forward with the presentation. I will return back and you should see the presentation again now. And we will move to start criteria. Because from the previous, it could see that the geriatrician is the one who only stops medication, but also there is this positive list. It's a screening tool to alert doctors to the right treatment, and it's evidence-based tool which helps physicians not to forget some important treatment which is possible and which has benefits for geriatric patients. The examples: antidepressants in the presence of depressive symptoms definitely should be used, not to forget about them. Other example, vitamin D and calcium. I'm sure you remember that vitamin D has much more benefits than only osteoporosis treatment and prevention. For example, vitamin D is essential in intervents of sarcopenia. When you want to support the muscle mass in your geriatric patient, definitely you have to intervene hypovitaminosis D, because only when you treat this hypovitaminosis, only then you can improve muscle mass, you can intervene sarcopenia in your patient. Other example of STAR criteria: ACE inhibitors or sartans in chronic heart failure when there is no contraindication. Do not forget about them. And another example, warfarin in the presence of chronic atrial fibrillation if there is no contraindication. So maybe now I would try to prepare another quiz for you. I will go back to the quiz mode, I hope, and quickly prepare it for you. Alright, just quickly. So, when you think about anticoagulation and atrial fibrillation is the indication, and the only factor which could stop you from prescribing anticoagulation would be 3 falls during last year, and one of these falls with injury, broken leg for example. And I will prepare the possible answers. It's very easy. Yes or no? Okay, so please vote for the quiz. The indication is atrial fibrillation. The relative contraindication would be that the patient has personal history of falls. During last year he had 3 falls and he had 1 injury, which was not fatal. Would you prescribe anticoagulation or not? Either warfarin or novel anticoagulants and NOACs? So each of you could vote. I hope you see the quiz, you can vote. Yeah, I see. Perfect. So 11 of you have voted. Of course, the risk is that when you start anticoagulation and your patient falls, the injury or the consequences of the falls may be worse. On the other hand, atrial fibrillation without anticoagulants treatment could lead to cardioembolic stroke, which may be very devastating. So you balance the risks, you balance the benefits. And I'm really curious on your decision. There are no other contraindications in this case. You would consider GIT bleeding, you would consider recent intracranial bleeding and all these, but there are no such things in personal history of this patient. Just falls. 80 years old lady with 3 falls last year. How would you decide? Yeah, the most of you have voted, so thank you. If some of you would like to vote, the last chance is now. I will stop the quiz. Okay, so stop now. Oh, this was better. Yeah, like this. So you see that 20% suggest that they wouldn't prescribe, while 77%, 14 people think, yes, I would still prescribe anticoagulation even though there is personal history of falls. I would say yes. Definitely, because when you compare the benefits, then the benefit of not having cardioembolic stroke is very, very important, while the falls, yes, it is a problem, but when you compare, then the cardioembolic stroke is much worse. I will return back to the presentation. Yes, here you can see it, and you can see the 2 scores which we use to assess the benefits and the risk. So you see the Chelsea-Wask score, which is the score of benefit, and the Hasblad score, which is the score for risk. In the Hasblad score, there are mainly recent serious bleeding events, such as GIT bleeding or intracranial bleeding. But none of these was the case of our patient in the quiz. And if it's only about falls, we have really huge clinical experience with geriatric patients who fall while they are anticoagulated, while they are on warfarin or NOACs. So usually just nothing happens. Maybe they have a more a bigger bruise or something, bigger hematoma, and it's not important for them. Just recently, like months ago, we had a patient, lady. She was like 86. She had a high calendar age, but her functional status was very good. And this lady, she was treated with anticoagulation because of her atrial fibrillation, and she had a really bad luck because she had a very bad fall on the stairs close to her home, and she had the fall on the stairs, and it was very bad, and she hit her head, and she had subdural hematoma. So she had to undergo neurosurgical intervention for subdural hematoma, but it was very successful. And then she went to the post-acute unit in the Center of Gerontology, which you know, and she received rehabilitation here and complex support, and she returned to her very good functional status really quickly. It was really nice to see her, how quickly she improved, how quickly she again was able to walk longer distances and then even walk the stairs again, even though she was afraid. But she was again able to, and she started to be again self-confident. So when we compare, even though she had a very bad bleeding complication of her anticoagulation, still her functional status was much better than was the functional status of her neighbor, who was a lady with atrial fibrillation, first manifestation like cardioembolic stroke, with aphasia, problems with swallowing, and hemiparesis, which was bedridden. So when you compare the outcomes of having and non-having anticoagulation, it's clear. So we are close to finish. To summarize, pharmacotherapy in older age. Clinical instruction is start low, go slow. Include in your consideration changes of pharmacokinetics, which usually lead to higher biological availability, and start with low dose and slowly make it higher and higher and balance the benefit and the side effects. Always consider polymorbidity and polypharmacy. And remember that stop and start criteria are there for you to support you in your clinical decisions. Okay, so that's it. We have finished with the presentation. I will come back to the discussion mode again. Okay, so now I would like to ask you, do you have any questions? First, concerning... I see you had questions whether I speak about novel anticoagulants or other things. From the basic point of view, it doesn't matter, either warfarin or NOAC. More specifically, dabigatran, Pradaxa, on one hand has the advantage of Praxbind. You have something to treat overdosing, and on the other hand, Pradaxa is the one which is the most dependent on renal function, and in very high age, renal function is too unstable. So, for example, in the United States, Pradaxa, dabigatran, is forbidden in the oldest age group. I think over 85, it's forbidden to use Pradaxa. So this is one information considering NOAC. The other one is that all the others, like Eliquis, Abixaban, are very good choice And in real life, even in the Czech Republic, we see them very frequently. So we see very frequently NOACs for atrial fibrillation in geriatric patients. Even though they are expensive, but they are more stable than warfarin, so it's a good advantage. I see you are writing your questions. You also can use your microphone if you have it on your device. So most of notebooks you can just switch on your microphone and say your questions just in words. But of course you can write. It's also a good way to communicate. How often do you need to check the inner in geriatric patients? So I will just speak. It's quicker than write. When you start with the treatment, then you check like every third day. If there is some serious outlying value, especially if you have very high value of warfarin all of a sudden and you have to intervene it, then you may check daily these values. But when you have someone who is very stable on his warfarin for a long period of time and you care for the patient as a GP, for example, I think GPs check the INR are once monthly, so once a month. Checking efficacy of NOACs, it's very individual. In fact, it's different for each of them. For Pradaxa, for dabigatran, you can use APTT just as orientation. For Xabans, you use other values, but it's very difficult. It's very difficult, and some of these possibilities are much more experimental than really available in clinical practice and very expensive. So usually it's not checked for NOACs. Maybe you could share your experience from other countries, but it's really very difficult. You asked about doses. You mean doses of anything? Like, what should I definitely know? Just, it depends on the branch of medicine you are working in. When you work as a psychiatrist, your spectrum is totally different from someone who works as cardiologist. So I think each of us makes his own essential core set of dosing. Aha, the other question, preference between warfarin versus NOAC. I could, of course, say it's case dependent. For many patients, NOACs are very good because they support compliance. It's so easy to take one pill per day or maybe two Eliquis tablets per day without any changes. Because warfarin is challenging as you change the doses from week to week, from month to month, according to the outcome of the inner INR check. So it's much better for compliance when the dose is always the same. So we really observe that more and more geriatric patients have NOACs instead of warfarin. Also because due to comorbidities, they are more unstable. So the effect of warfarin is much more frequently unstable in geriatric patients. But one great advantage of warfarin is that when you overdose it, you just give vitamin K and that's it, you know. So in patients who are unstable and risky, you sometimes use neither warfarin nor NOACs, but you use low weight heparins. It's also a possibility, at least for some shorter periods of higher instability. Yeah. Any other questions? Aspirin has other indication. For atrial fibrillation, it's believed now that there is no use of aspirin at all. Aspirin prevents stroke, aspirin but not the cardioembolic one, just the classical, and prevents myocardial infarction. So it's different mechanism. I see there is someone else writing the question, so I will wait for it. I just see people are writing. No, I wouldn't say that every geriatric patient should receive aspirin. No, only if indicated. If it's secondary prevention of stroke, secondary prevention of myocardial infarction, definitely yes. If there is ischemic disease of lower extremities, okay. So if there is indication, then yes, but not without indication. Maybe this remembers me the question of statins. Maybe you would be also interested in the question of statins in geriatric age? Yeah? So, the question is, and I will make it another, I will try to make it another quiz, okay? New quiz. Statins. 85 years old. Indication exists. This means there is some standard indication to statin, and possible answers are always yes, always no, yes, if okay. So you can answer. I ask you about statins in case of a person who is 85 years old, has indication. This person has mild cognitive impairment, but very good mobility and quite okay with self-sufficiency. Independence is quite okay. And so could you please make your choice? LE means life expectancy. Maybe someone wanted to ask about this. So LE is life expectancy. Very good question. No serious kidney problems. I have added one more possibility, which says yes, but lower doses because of biological availability. So you can just choose anything what you want. I have added more possibilities, and I'm really curious which one would you prefer. Uh-huh. It's really interesting. So thank you very much for your choices. Everyone who wanted to vote has voted. You have the last possibility now. Okay, so you see the outcomes. Always no, 2 people, 11%. Yes, if there is longer expectancy, not much preferred, just 3 people. Uh, yes, but half of usual doses, not so much preferred, 3 people. And yes, if the patient tolerates it well, has the most of the votes, 9 people. Okay, so when I comment this, there exists interprofessional consensus on statins in geriatric patients. It's a consensus of geriatrics internal medicine specialists on atherosclerosis, and the consensus is that statins only when there is indication. This is the case here, independently of calendar age, so it doesn't matter that the patient is 85, it's no problem. So always no is incorrect, it's not correct answer, but you have to consider life expectancy, and it is the consensus is that statins are really worth and really beneficial if there is life expectancy only of over 5 years, which still could be the case of the patient who is 85, no problem. Um, and what is really important is the last choice, which are added later. So yes, you prescribe if it's indicated, and if there is some good prognosis, so that the benefit of statins needs some time, needs years to be really beneficial for the patient. So there is the time, the prognosis is good. And what's important, you prescribe really low doses of statins because of much higher biological availability. You remember, this is the drug class with high first pass effect. So in statins in general, the first pass effect in geriatric patients is much lower. The availability is twice or even more times higher. So you prescribe really very low doses. So I think those who have chosen that the patient tolerates it also thought about this aspect. Okay. Any other questions about pharmacotherapy? If not, we can move to the other topic, to the topic of COVID. I will try to share um, um, this with you. So I hope now you can see the statement of the European Society of Geriatric Medicine on COVID epidemic. I would like to share it with you. If you want, I can send it via email. And also I have added this EUGMS statement to VUCA on web pages of VUCA so that you can find it here. And this Geriatric Medicine Society says that older adults are really at very high risk of serious complication. The mortality rates are considered now about 15% over 80 years, which is much more than in younger people. And this statement wants to point out some special aspects and consequences in older people. So the first one, this one is consider carers, family carers and professional carers, which are potential contacts, and all these care people have to be educated and provided with antiseptic facilities, and also supported to have sick pay if they are unwell, not to be economically forced to stay at work even though they could be the contacts, the carriers of COVID. So this is the first point. The other point is that, and this one is the most important, advanced age, a calendar age itself should not by itself be criterion for excluding patients from specialized hospital units. This is really important, that this should not be decided just depending on calendar age. The other aspect is that the most of people who died on COVID or died with polymorbidity and COVID positivity were people who were not at ICU. They died on basic beds of hospital or even basic beds somewhere in nursing homes. So this is a really important aspect of it, that denying specialized hospital care to the oldest people has the highest contribution to its serious consequences. We will discuss it. Maybe we can go for discussion mode now, so I will stop the sharing. Okay. So your questions? Maybe the easiest way would be to turn on your microphone and just discuss it. So anyone wants to ask something or discuss experience from his country, her country? I've read in the news that, for example, in Spain, in some hospitals they do not have enough capacity for all patients, and they set just the arbitrary cutoff for the age 75. That over 75 people are not accepted at ICU. So this is really very difficult for everyone. And the suggestion of EUGMS is that you should not have calendar age as cutoff. You should use functional status and advanced care planning, if possible, to decide in these difficult situations. So I wait for your reactions. I see that some of you are writing reactions. So I will start with the second question. With the massive influx of patients, doesn't triage necessitate calendar age distinction? If it's really massive and you do not have time to think at all, yes, then it's like war triage, you know. So probably then you will use it. But at any point before this worst point. You should use rather functional assessment and advanced care planning. And this is the consensus of critical care society of physicians in Belgium. And they ask everyone, please, before it's so massive, uh, for example, for GPs and for physicians from nursing homes, for the chronically very ill population, please consider advanced care planning. So in advance, consider whether this patient will really have benefit to move to hospital or not, because advanced care planning is something you do with very ill people who are maybe in palliative regime, symptomatic care only, with some terminal illness at the terminal stage. So if you do not send these people in hospital, it's better benefit for them, it's better comfort while the death is inevitable, and then you are able to admit to hospital other people which may have even higher calendar age but much better functional status and much better potential to really recover. I hope I'm understandable when I explain this. Just ask me. Do we test the staff working in geriatrics more than others? What precautions have been taken to decrease healthcare workers bringing COVID to their wards? In the Czech Republic, it's quite bad. At the moment, there are not enough tests. Those tests who are here, some of them available, do not have good quality. So this is really a problem. This is definitely very good point. We should test geriatric staff more frequently, even preventively, but at the moment there are, at least in our country, I think there is not enough tests, and the situation realistically does not support this. But the idea is really good, and if you work in a country which can allow this, this would be very good. I will wait for other questions. I see you are writing. I see the other question at the beginning. What situation is in Královské Vinohrady now? What are the areas that require help the most now? I'm sorry, I'm not coordinating this, but it's a very good question, and it would be great if you try to find a coordinator who has the overview. But my clinical base is Center of Gerontology, so the clinical part of me is somewhere else, so I wouldn't be the best one to advise you. I see that you are writing your questions, so I wait for them. So the main precaution so that healthcare workers do not bring COVID to their wards is using the mask or better respirators for healthcare staff working there. You wear your mask not only to protect you, but especially to protect your patients. And of course, using disinfection. There also exists a recommendation of WHO, World Health Organization, on long-term care, and they also it's very they are very well-structured instructions for each member of the team of long-term care, for example, including cleaners, those people who just go and clean the rooms of chronically ill people in nursing homes. These cleaners definitely should have very high level of protection, including the eye protection, because when they work with the cleaning, they may also create aerosols, so they should also wear protection of eyes, not to be the COVID contact for all the inhabitants of the world. Any other questions? I just have a writing, but I do not see the questions yet. Chloroquine azithromycin combination. Uh, it's very promising. We do not know yet. So there is not yet a definitive recommendation. There is not yet definitive consensus, but it is surely promising. And for example, in the Czech Republic, the Ministry of Health already required all the chloroquine to be only for the wards treating COVID. So now you cannot just prescribe chloroquine to anyone except for people who already were taking it as their chronic medication, for example with lupus erythematodes. So you cannot prescribe to a new patient, and all the tablets of chloroquine now are like in use of the Ministry of Health, because it is expected it will work for the patient. Contraindication in geriatrics. For azithromycin, I think it's quite okay. Shouldn't be worse than other antibiotics. Chloroquine. I have one experience with very strange side effect of chloroquine in geriatric patient, and it's patient with rheumatic disease, and she was prescribed chloroquine, and her side effect was that she had really only when she was taking this medication she felt to be forced to commit suicide. This is really strange, but this is my clinical experience, and I hope it's not it's not frequent. I think it's extremely rare, but this is what I observed. I have not found some overview, some summary, so I will have to find it. I would like to share with you one link. I hope it will work. I will see. No, it's too difficult. COVID task force. This is the European Society of Geriatric Medicine, and then they have on their webpage COVID task force in the form of questions and answers, and also they are trying to summarize all the clinical guidelines from different European countries. So I think this is a very good source for actual information for you. So when you look for EU GMS COVID Task Force, it's just at the beginning of their web page. You can see quite a lot of materials and questions, answers on the topic. So if you have some more questions, we can stay and discuss. To the others, thank you very much for your interaction. It was very interesting for me to try this new interaction on the webinar. It's fine that it worked. It is fine that even the quiz worked. So thank you very much for your interaction, and I wish you all the best and good health in the next months. Yeah. Bye bye. Thank you also. It was really nice to meet you here in the webinar. I see Sarah is writing about the approach to geriatric patients and about frailty. Important points in frailty. Okay, so we start with the meaning of frailty syndrome. Frailty syndrome has really a definition which is quite strict. So there are 5 symptoms of frailty. I hope I will manage just out of my head. So it's losing weight, slow walking, low physical activity, low habitual activity like walking, and the one, subjective exhaustion, fatigue, and the last one, low strength. For example, you can measure it via hand grip. So these 5 quite basic things, quite banalities. Frailty syndrome is composed out of these 5. When you observe 3 of these 5 symptoms, you can say that there exists frailty syndrome in your geriatric patients. Each of the points is defined, also has its own definition, like the low muscle strength has definition when using some dynamometer, for example. And all of these points is defined. We had very interesting discussion with the Society of Palliative Medicine. They wanted all the physicians to support the existence of palliative teams in hospitals, which of course is a good thing, and as Geriatric Society board we would support it. But they wrote there that palliative medicine is very good for people with terminal diseases, and the examples were terminal heart failure, perfect. Terminal stages of oncological disease, perfect. Terminal stages of COPD, renal failure, yes, of course, all of this. But the last example was geriatric frailty, and we were really angry as this is misunderstanding. Because being frail is just a syndrome, it's definitely not a disease, and it's definitely not terminal stage of disease. It's just syndrome and it's reversible. So it's something you can intervene and you can be successful in intervention of geriatric frailty. So maybe this is the point. And when you want to intervene geriatric frailty, you support the muscle mass and you support the activity. And very important part of it is active treatment of chronic pain. I could talk for a long, for example, now we have very good cooperation of me as geriatrician and the transplantologist ward in ICAM because transplantation, renal transplantation is really actual even in people over 70. And these people undergo geriatric functional assessment, geriatric examination, and we assess if there is frailty or not. And if it's there, number one, the indication is considered, but maybe still the indication may be here, but we always intervene the frailty. So these are my first thoughts to your question. I see you're writing, so I will wait for your next question. Also, you can just use your microphone, you can just talk, it's really easy, it really works. So you just turn on. No. Not all 5, just 3 out of 5 symptoms. Okay, just 3 out of 5. So, for example, when the patient walks slowly, doesn't walk a lot, and feels tired quite soon, which is so frequent in the whole senior population in our country, then you consider the patient to be frail. Yeah, you're welcome. Any other questions? Because I think this frailty patient, it's one question in the state exam, right? Yeah. It's good that you remembered it to me. I will, for the next time, I will prepare it also as a short presentation on frailty patient, because we were so surprised by the misunderstanding of the palliative care society. There are also other syndromes like geriatric deterioration or terminal geriatric deterioration. Approach to geriatric patients. Okay. So when you talk about approach to geriatric patients, you can talk about everything. You can talk about microsymptomatology, which you remember from the 4th year, and the lecture is interrelated with the calendar, so you can easily find it. So you can talk about microsymptomatology a lot. Oh, and definitely you can use anything about pharmacotherapy in the old age, about changes in pharmacokinetics. This is really interesting, really important, and I think could be impressive when you are answering this question. Any other questions? Okay, so thank you and good luck, and I wish you good health. Nice to meet you. Thank you.